This is Danny Bobrow, President of AIM Dental Marketing, welcoming you to this installment of the Practice Perfection Web-Based Education Series. Today's presentation is entitled 13 Things Never to Say to a Dental Patient and What You Should Say Instead. It is a genuine pleasure and honor to welcome the GEMS Guy himself, Dr. Tom Orent, to the Practice Perfection stage. Tom has lectured at dental schools and societies in 48 of the 50 United States and in 5 countries. He is an Amazon #1 best-selling author. His gems have been used by dentists in 47 countries around the world. Tom served as editor of the AACD Journal, has authored 4 books and hundreds of articles on aesthetics, profitable dental practice management, TMJ, and extreme customer service. He is that rare combination of clinical dentistry, practice management, and patient communications master. And that's why we're so excited to have him join us today. Tom has worked one-on-one with hundreds of practices through his Freedom Summit Dental Practice Transformation Coaching Program, which includes a $300,000 guaranteed increase. He is renowned for teaching dentists how to gain far higher case acceptance of best option care and how to earn more while working less. As an attendee at today's presentation, you will learn 13 gems that will quickly increase your job satisfaction and profitability by upping your patient communications game. Now, before we get started with today's event and very special presenter, I remind you that Practice Perfection webcasts run for around 90 minutes. While attendees are in listen-only mode, we invite you at any time to submit your questions or comments using the question button on your screen. We will allow time following the presentation to get your questions answered. If we do not get your questions answered during the webcast, we'll be sure that they're done shortly thereafter. Attendance at this presentation entitles you to receive 1.5 hours of PACE-approved continuing education credit with the compliments of Tom and AIM Dental Marketing. Shortly following the webcast, you will be emailed a brief survey and quiz to complete and receive your CE, again, at no cost to you. Participants are cautioned about the dangers of incorporating techniques and procedures into their practice if the course has not provided them with adequate clinical experience to allow them to perform them competently. And with that, it is my distinct pleasure to welcome my good friend and colleague, Dr. Tom Orent. Hello, Tom.
Hey, Danny, how are you tonight?
I'm doing great. Thanks for being here.
Thank you so much for the invitation. So thanks to Danny, also to AIM. Really excited to share with all you guys tonight. And I really appreciate you taking the time away from your family. And I know there's other stuff you could be doing, so let's get right into it. If you are concerned that, maybe you or your team, or more likely both, are sometimes saying stuff that might just turn off a new prospect. You get somebody on the phone, they're calling up. They're not a new patient on the phone, by the way. The people on the phone who haven't been to your office that are not new patients, they're new prospects, because you got to get them appointed and you also got to get them to show up. So maybe there's stuff that's being said on the phone. Maybe some of the stuff that you say might harm your case acceptance. So you're presenting a quadrant of dentistry or implants or an aesthetic case, and something you or something the team said actually kind of took you in the wrong direction. Even maybe offend existing patients, and ultimately all of these things will cost you money. So just because they forgot to teach us a few of these things in dental school, like basically all of it, but I'm preaching to the choir on that one. So maybe you're frustrated realizing that the type of harm that you could do to your patient relationships, or that your team members might inadvertently cost you financially. You want to keep more of your patients. Some of them leave without ever saying anything. Most of them don't, call you and say, by the way, here's why I'm leaving and I'm out of here. They just leave and they go somewhere else. And maybe it's something you said. We'll get into one of those tonight that was actually said to my mom, caused her to leave the physician's office, and she liked the physician. So these things are very real. They're happening every day, and usually you don't know about it. I should probably let you know ahead of time that I'll be drinking tea occasionally, just so I don't sound rude drinking tea in the middle of the presentation. You can probably already hear it. I have permanent vocal cord damage, and my surgeon said the cause of it was I talk too much. So anyway, he said, don't talk so much. You want to improve the clarity of communications, and if you can improve your verbal skills, if you can improve what you say and how you say it, and what your team uses for verbal skills, the whole practice is going to improve, and so will your future. And you certainly don't need to go back to school for any of that. There's stuff you're going to learn tonight that's going to be immediately applicable starting tomorrow. You're in the right place. That's exactly what we're going to do. The big secret is knowing exactly what to say to whom and when is probably one of the easiest things you could do to improve your practice, and of course, improve your future. So let's talk about verbal skills for a moment. The highest paid actors and actresses, the people who you see, they're walking the Hollywood, the red carpet, they're making huge, millions and millions of dollars. They all start with a script. They all start with a script. The most successful salespeople that earn 7 and some of them 8 figures, they all work off of a script. And yet, when I had 2 practices, I practiced clinically for 22 years, and we had 35 team members, and we would occasionally have a team member saying, I'm not really comfortable using a script. I'd rather just speak from my heart. I'd rather just tell them, what I feel and what I know, and not have to use something that's not really my words. And what I would tell our team members is, it would be fine if that was the most effective way to communicate with our patients, but it turns out it's not. You need to learn the verbal skills. That doesn't mean you have to use every verbal skill word for word. It simply means start with something that's been proven, and then if you need to change something at some point later to make it a little bit more your own, that's fine. But and they got that, and they did extremely well with that. Our goal is to help our patients achieve optimal health, and I should add longevity, because you know as well as I do about the oral systemic link, to the point where over the last decade we've all learned more about the oral systemic link than we probably knew at any point prior in time in dentistry. So our goal is to help our patients achieve optimal health and longevity. To have that happen, we have to know how to ethically persuade them of the need for treatment. And if you've got a notepad, or if you're taking notes on a computer, whatever you're going to do to take any notes tonight, please write this down. 95% of our patients, unless you're an oral surgeon, 95% of your patients have no symptoms. Yet they have all of these problems and issues that they come in with that they don't know about. And for us to be able to convey what we see, and the imperative nature of getting these things scheduled and getting them done, we got to be able to help them perceive the need, actually write down, perceive the immediate and urgent need for care in the absence of symptoms. And that's something to discuss with your team. We're not going to go into great depth on that tonight, but the point is, talk to your team about that most patients, when they say it's money, or they say it's time, or they ask you if your insurance covers that, or all the other excuses that they give you, those are all very valid reasons, but none of them are the real reason that they don't schedule. And I shouldn't say none. I mean, maybe there's an occasional patient who has no money, no credit, nothing, but most of our patients could afford to do the care that you're recommending right now, even if it were done, a few teeth at a time, a quadrant, whatever. But the reason that most of them say no is not what they're telling us. The reason they're saying no is because they don't really believe that there's a problem, or even if they kind of get that there's a problem, even though there's no symptoms, and maybe you've convinced them a little bit, we certainly haven't convinced them of the immediate and urgent need of that problem, or they'd be scheduling. It's just what happens. So with all that said, tonight we're going to be discussing a wide variety of verbal skills. Some of them are all about case acceptance. We're going to talk about conversion of new prospects on the phone into a patient in your chair. Maybe a little bit about financial options. You might look at some of the blunders I'm going to cover and say, that never happens in my practice. Nobody, neither the doctor nor any team members in my practice, have ever said that. Chances are some of them have been said in your practice, and others you're going to recognize painfully as things that your team and you may be routinely saying. That's just part of what we say. It's common. It's not right, but it is what we say. Some doctors express frustration to me. They say, Tom, I taught them these verbal skills. I went over this before. Danny and I were talking earlier about one of my mentors in business and marketing, Dan Kennedy, and he taught us years and years and years ago, decades ago. Dan said, if there are important verbal skills that help you to get across to your customer, client, or patient, whatever it is you want to get across to them, in our case, it might be a patient and case acceptance, and you've gone over these verbal skills and you've all practiced them, you've role played them. Dan said, you're kidding yourself if a month or two later you expect your team members to be using them the way that they were meant to be used and using them effectively in action with your customers, clients, or in our case, our patients, unless you're repeating the role play and repeating the practice sessions of these at least once every month or so. So I don't think that's anything that we've really been taught, but it is critical. It is so critical.
Just
So
like
don't be
clinical,
frustrated.
right?
Say again?
You want to learn, master your clinical craft. You have to practice. You don't do it from hearing about it one time.
100%. So Danny just, he hit the analogy is 100% right, because if you think about it, now maybe not a DO amalgam or something like that, which you're doing every day, but, or maybe you're not, maybe you're doing DO composites, inlays, onlays, crowns, implants, but the things that you do every day, all day long, that are fairly simple and straightforward, the basic stuff, maybe you don't need to practice that. But what Danny's saying is maybe you're about to do an implant with an abutment that you haven't used before, or a torque wrench that you don't only use once every few months. Whatever it is, you need to study it, you need to practice it, you need to make sure you're on the top of the game to make sure that these things work right. The nice thing about verbal skills is they're easy to learn, they're super simple and easy and quick to practice, and they will change your practice. So don't be frustrated. It's an ongoing process. I asked myself, can a few quick, easy changes in my verbal skills really affect my bottom line? And the answer is, yeah, in a big way. So let's jump right in. Grab your pens, get your keyboard ready, however you want to take notes, whatever it is. And we're going to start. So number one, how to avoid leaving easy money on the table when working out the deposit for a payment plan. So this is your business team member, might be your office manager, whoever's responsible for working out the payments. And the exact number doesn't matter. I'm going to choose $2,000. So let's say you got a $2,000 treatment plan. And just for ease of numbers, the patient doesn't have any insurance, so it's $2,000 bucks. Or if they do have insurance, their estimated portion is $2,000. So bottom line is the patient's going to owe you $2,000. So your financial options worksheet, which is the thing that you kind of go by and your team goes by to what are the options. Let's say it says 50% down, and mine always said 50% down. Now, I wrote 50% down, but I told my team members, we don't need 50%. I just want to put that there so that, whoever's going to pay 50% will pay 50%. But I said we could go as low as 30%. I'd still be happy. So maybe it says 50% down and 2 payments, one in 30 days. So you got the 50% today, and then one in 30 days, one in 60 days. As an aside, and tonight's program isn't about financial options, but I do want to point out, because this is critical, whatever payment plan you have, whether it's 50% down and 2 payments at 30 and 60 days, I don't care what number of payments it is, all of that, never, ever, ever expect to get the money unless you have the instrument of payment in hand ahead of time. So even if I gave a patient 6 months, or in some cases we did long-term internal financing, which is a whole nother discussion, but long-term internal financing, we would charge an upfront simple service fee. You don't want to charge interest because of all the different laws that they would have to follow, but a one-time upfront simple service fee, and then we would take again, a down payment, which would be minimum about 40% for long-term internal financing. We'd go up to a year out. But whether it's 2 months, 3 months, or something long like that, you got to have the instrument of payment in your hand. Now, what's the instrument of payment? It could be anything. It could be a MasterCard with a form signed that says that they've given you authorization to charge this credit card on X dates for Y amounts for the dentistry that you're doing. And so you've got that on file. You're keeping the credit card in one of those online cloud vaults, so it's all secure. And you've got the right to charge them on those dates. Or maybe it's ACH, EFT, electronic transfer, bank transfer, account to account. And again, you'd have a form from your bank you'd fill out. It could be post-dated checks. In some states they don't allow it, but a lot of states do allow that. So we did a lot of post-dated checks as well. It doesn't matter what the instrument is. What matters most is never, make sure your team knows this, never allow a patient on a payment plan to have to send you the money because you'll never get it. So anyway, let's get back to the verbal skill. Sorry about the diversion, but I can't leave that one because I don't want you guys to get burned by patients on a payment plan when, as long as you've got the instrument of payment, you got to, obviously things can still go south, but very, very rarely in relation to if you, or conversely, if you didn't have the instrument of payment. So it says 50% down. That's what they see on the paper. I've already told my team members, look, 30% is fine if they can't do the 50. So Mrs. Jones says to your team member, you know, Mary, I can't come up with $1,000. So that's the 50%. I can't come up with $1,000. Tell your team members not to give away the store at this point when she says, I can't come up with 1,000. They don't want to tell Mrs. Jones, well, we could go as low as 30% if that would be, you know, more comfortable for you. No, don't give away the store. If she says, you know, your deposit would be just $600 if we did 30%, can you do that? Would it be more comfortable? The patient might have been okay with 40%. So the fact that you're okay with 30 and you've written down 50, here's the verbal skill. So if you're looking for exactly what they should say, when Mrs. Jones says, oh, 50%, that's $1,000, I can't do that. So I would have your team member say, I understand, Mrs. Jones, 50%, it is a lot all at once. What amount would be more comfortable for you to start with? What amount would be more comfortable for you to start with? I really love that phrase. It's from the heart. What would be more comfortable for you? Now, the patient might say, well, you know, I could do 40%, you know, I could come up with, you know, whatever the amount is, it's 40%. Or so if they come up with 40 or something higher than 30, then you're in great shape. Now, if the percentage of the whole amount is less than, you know, the amount that you want to accept, which is 30, she says, Mary, I could only come up with 20%. Then you need to tell them you'd like to help them. So you always be empathetic. Mary, I'd love to help you. 30% though would be the least amount with which we'd be able to start the case. Unfortunately, because of you can mention our costs because we do have a lot of costs. You need to tell them that. So if this comes to that. So unfortunately, because of our costs involved to perform the case, the least that we could start with would be 30%. All right, number 2. The one question never to ask a caller on the phone. And by the way, remember I said earlier, I kind of pre-framed this by saying some of these things I'm sure you're not saying. Others of these things you're going to recognize as, yeah, that's exactly what we say. So this question is something that is frequently asked by team members and totally innocently. Mrs. Jones, it'd be a pleasure for me to set up an appointment for you. Are you a new patient? So somebody calls up, they don't know the person, and the person says, yeah, hi, this is Mary Jones. I'd like to schedule an appointment with Dr. Smith. And they say, Mrs. Jones, it'd be a pleasure for me to help you set up the appointment. Tell me, are you a new patient with us? So the caller on the phone says your receptionist's the name, and the fact that your receptionist or business office manager doesn't recognize her name isn't necessarily an indication that she's new. Maybe you're fairly new, the receptionist or the business manager or whatever, or maybe you just don't remember the patient. She hasn't been in a year and a half. Whatever the reason, obviously the first thing you're going to do is type the name into your computer because you've got the computer right up and right there on enter the contact's name. You put the name in, and it doesn't come up. And that's why our team members are often asking, "Are you a new patient?" Because they did put them into the computer and it didn't come up. Maybe she's using a nickname, or maybe in the computer there's a nickname and she gave you her full real name, or maybe she said it's Mary Smith and your team member typed in Smith, S-M-I-T-H, and it was S-M-Y-T-H. Doesn't really matter why the mistake occurred. One of the most, I won't say frustrating, but the patients they could be offended. A longtime patient could be offended by your team member asking them, are you new here? And they've been with you for 8 years and they've referred 3 patients and they've done $10,000 worth of care. So I would urge you to tell your team members, don't ask the question, are you new here? There's a really simple way of asking them, and that is, Mrs. Jones, roughly when was the last time you were in our practice? Now, this is if you can't find them on the computer. If you find them in the computer, you're all set. But Mrs. Jones, roughly when was the last time you visited our office? It works like a charm because their answer is always going to be a rough number. They can say, I think it was about it could have been a year and a half ago, or I'm not sure. it doesn't matter exactly the time period. The point is, now you know you need to figure out where are they. And now, if they're a new patient, when you ask them, when was the last time you visited our practice, they're gonna say, oh, I've actually never been to your practice. I'd be a new patient, to which your team member should respond something really, really positive like, great, welcome to our practice. You called the right place. We are delighted to have you with us. And by the way, I am not even slightly exaggerating with my tone or those words. That is wonderful. Welcome to our practice. We're thrilled to have you with us. You certainly called the right place. Let me help you. I'll help you. I'm happy to help you right out. So again, really, really positive. All right, that was number 2. Number 3 is a single word substitution during exam and case presentation instantly improves patient comprehension, and because it improves comprehension, it will also improve acceptance. We might assume that decay under your filling, if we use that phrase, which we all do, and by the way, I have this discussion with dentists and team members literally every day. Literally, this discussion comes up. It came up this afternoon talking to a hygienist at a dental office in Connecticut. Decay under your filling. Anyway, you would assume it would make sense that when you say you get decay under your filling, so the hygienist is doing a recall exam and looking at the x-rays and looking in the mouth and whatever and says you get decay under your filling, you would assume that would be clear to the patients. It's plain English. And it's exactly what I used for years and years and years. So I was working with one of our Freedom Summit coaching members in Hawaii, and one of the dental assistants says to me that her hygienist taught her the best gem, and I call everything a gem, an idea. So she says her hygienist taught her the best gem to say when she sees decay under an old filling. And she said to me, Dr. Orent, did you ever notice that you can explain to a patient what I just said to you guys, which was that you tell her she's got decay under the old filling, and you finish the exam, she sits up, she looks at you, and she says, okay, okay, do I have any cavities? And you're all probably kind of smiling to yourselves because you've heard this. And if there are hygienists on tonight, and I hope there's some hygienists on as well, if you're a hygienist, you've heard this. You just told them they've got decay under a filling, and they're saying to you, oh, yeah, okay, but do I have any cavities today? It's like, hello, seriously, you're gonna ask me that question? But you would never say that. So she shared the gem. And so she said, instead of saying the word decay, use the following sentence. You have a new cavity under your old filling. So just substitute the word new cavity for decay. You have a new cavity under your old filling. And you guys, if you share this with your hygienist and your assistants and everybody starts using this in your practice tomorrow, assuming you're practicing tomorrow on Friday, you're going to be shocked at how easily they accept and understand that, the improvement in patient comprehension, when you just say, yeah, you got a new cavity under your old filling. Number 4, the worst question and the most common question asked by team members when scheduling patients' next visit. And the question that they ask, which you should never ask, is, Mrs. Jones, when would be good for you? Mrs. Jones, when would be good for you? This is what I call giving away the store. What time is good for you? You already know that there are some appointment times in your schedule that fill quickly, and there's other times that are really, really tough to fill. So you're always trying to get those filled, but they're tougher to fill. And so, what are the times that are going to fill in a heartbeat? Now, it varies depending on your location. So if somebody is downtown, I have one member, Dr. Jill Smith in Boston, who says that the most tough time to find any openings, because they fill immediately, are 11 a.m. to 1 p.m. It's basically lunch in downtown Boston, and people flood out of their offices and go over to her office and try to get a midday appointment. We were suburban in both of my practices, and so suburban, it was just the opposite. Midday was the tougher to fill, and the 7 a.m. to about 9:30, and the 4:30 until whatever time you close. But it doesn't really matter what the times are. What's tough to fill. What's easy. And so what I would recommend that you tell your team members is, don't give away the most sought after appointment by just saying what's good for you. I would use what's called a dual alternative assumptive close. And I would write that down, unless you probably already know what it means, but if you don't, no worries, write it down now. Dual alternative assumptive close. So first of all, you're not going to ask her if she wants to schedule. You always assume your patient wants to schedule unless they said, I'm not scheduling this, in which case you have a problem. But unless they said, I really don't want to schedule right now for some reason, always make the assumption. So that's why it's called an assumptive close. Dual alternative is simply what it says, which is you're going to give them two alternatives. So Mrs. Jones, let's schedule your next appointment. We have Tuesday at 10 a.m. We also have Thursday afternoon at 2 p.m. Which one of those would be better for you? I'm going to repeat that. So it would be Mrs. Jones, let's schedule your next appointment. We have Wednesday at 11 in the morning, and we also have this Friday afternoon at 3 o'clock. Which would be better for you? So again, you're giving them two options on two different days at two very different parts of the day. Two options, two different days, two different time periods, but always days and times that are harder to fill. Now, sometimes they're just going to take one of the things that you just offered them. If they're pretty flexible, they're going to choose one of the two options. And that's really cool because yeah.
It's got a variant on the alternative close, the assumptive close, the alternative options is some of our health partners use the following phrase, which is, do you have a particular day in mind, or would you like first available? And that sort of also has a goal of not giving away the store, keeping you somewhat in control, because most people will say, well, what's your next available? And then you're back in control of your schedule.
Okay. It certainly works. As long as your team members aren't just asking what's good for you. I like it. I totally like it.
Okay.
Let's do this. Let's go to number 5. Number 5 is 2 words that curdle my blood and fry my hair. And if I know there's no video tonight, but if you've ever seen me before, actually there's a picture of me down in the bottom left-hand corner of your screen. It's not actually a photograph, but it's darn close.
With a hat.
What's that?
You got a hat on though.
Yeah, but you can pretty much tell that they're.
We can infer.
Let me just explain that if you were to pull the hat back, the hairline is at the back of my neck.
Gotcha.
All right. So you and I are kind of twin sons of a different mother.
We are.
So the 2 words that curdle my blood and fry my hair when discussing periodontal infection. So you did some, your hygienist or the doctor did some periodontal measuring, and you came up with 4s and 5s and 6s and bleeding, and they've got a periodontal infection. These 2 words are said more often than I can believe still today. And the 2 words are deep cleaning, deep cleaning. It is one of my pet peeves. Of course, I got a lot of them. We've only been together for about 28 minutes, and you already know I got a lot of pet peeves, but this is one of them, and it's a big one. I had a periodontist. His first name was Jean-Marie. That's actually his first middle, but anyway, Jean-Marie. He was amazing. This guy was just outstanding. I called him my hired gun periodontist because he served in both of my practices. We had perio, endo, and ortho, and he was our periodontist. He was great, but every once in a while, Jean-Marie would say something like this. He'd say, "Oh, Mrs. Jones, we're gonna need to start you off with a deep cleaning visit." One time I was walking by him and I heard him say that, and I'm not kidding. I almost slapped the guy upside the head, right in front of the patient. Now I didn't. I restrained myself. Instead, I bit a hole through my cheek. You know, a patient has a periodontal infection, and you start using the words deep cleaning. You create confusion. It's going to be really hard for you to convince your patient why she needs any more cleaning at all. She's already had her cleaning, and she's going to wonder. And sometimes they even ask, but you know, she's at least going to wonder to herself, did the hygienist do such a poor job with my cleaning that he's saying or she's saying that now I gotta come back and I have to get another cleaning? So I just got the cleaning. This has never happened before. I've been in other offices where they did a cleaning in one visit and it was fine. And you know, I'm sure they went deep and did a thorough job, and I don't get why this hygienist wasn't able to do it. And these are all thoughts that run through their minds. And some of these thoughts, the reason I know this is that some of these thoughts are actually expressed, and they just don't get it. To the patient, it sounds like when you say deep cleaning, to the patient, it sounds like the cleaning that they just had, but deeper. And you mean something entirely different. And the patients can't help associate it. They can't help but associate it with routine cleanings. So even if they kind of get that they need to come back, so okay, so maybe they didn't get everything, maybe way down deep, there's more stuff down, so they kind of get it. Now they're wondering, and often this is something that they vocalize, why is this so much more expensive than the cleaning I just had? Why am I paying anything at all more, and why so much more? Because in most offices, if you had to do, let's say you had to do 4 quadrants, you had to do the whole mouth of perio. And obviously not every patient needs the whole mouth of phase 1, but let's say you're doing phase 1, deep scaling and root planing, and let's say you're talking 4 quadrants, and we can't discuss fees because that's not legal, but I will say that comparatively to the cleaning and checkup that they just had, it's going to be anywhere in the vicinity of, for the full mouth, let's say about 6 or 7 times that fee, and it could be even more than that. So the patients are kind of astounded by this whole thing. Some of the patients actually lose it, because during the cleaning visit, you tell them they need to come back for a deep cleaning, they need to pay all this more money, and they, new patient says this is why they left their last dentist, was because, all right, so there's an easy way to get around this, really easy way to get around this, and I made this term up, so you probably have not heard this before. First of all, remove the words deep cleaning from your vocabulary. They should never be used. If you're talking about phase 1 perio care, which also you shouldn't use because that's all jargon, it's a different diagnosis. It's a different treatment. It's a different number of visits. In many cases, it's under anesthetic. All right, so it's 3 words. Gum infection therapy. Again, write it down. Instead of deep cleaning, instead of scaling and root planing, which is very scary sounding, just use the words, we're going to be scheduling you for gum infection therapy visits. All right. Exactly what to say to your new patient emergency to ensure that they will want to come back for a comprehensive exam. Now, if you have, let's do some math. I love kind of forecasting. What could you do if you did this gem, any gem, well? So if you have just 2 emergencies in a week, which most of you have, some of you have that many in a day. Others of you might have 1 emergency in a day, but I'm saying if you just had 2 emergency patients in a week, so that's very, very conservative, that's 100. If you increased your conversion from emergency who never comes back to routine care and now they do their case, whatever's necessary, just by 10%, that's 10 more new patients. So 10, again, very, very conservative numbers, 10 more new patients. The average lifetime value of a patient in a general practice in the United States is $4,800. Now yours is probably higher than that, depending on where you are, because obviously fees vary widely. But if you say, wow, mine's actually quite a bit higher, you're probably right. Yours could be 5,000, 6,000, 7,000 average. But 4,800 is a conservative number. So 10 extra new patients per year times 5,000, it's close to $50,000 from this strategy. So it really, really pays, pardon the pun, but it really pays to get this right. Otherwise, they ain't coming back. Until they have some other emergency, but they're not coming back for routine care. A new patient presents for an emergency dental visit, comes into your office, brand new. Let's say she fractured a tooth, broken tooth. She'd been seeing a dentist for routine care. I'm sorry, I misstated that. If she had been seeing a dentist for routine care, regular dental visits, maybe she could have prevented the situation. But instead, she waits until this thing becomes an emergency, and now she's sitting in your chair with what she considers, and she's right, it is a dental emergency. So you take care of her emergency, whatever you're going to do, whether it's an onlay or a crown, or maybe you could do a filling, but whatever your treatment is. And then you say to her, Mrs. Jones, and by the way, did you ever notice that all of my patients are named Mrs. Jones? It's kind of freaky, but it's true. All of my patients were named Mrs. Jones. We had 6,382 patients over the last 5 years in practice, all named Jones.
I have noticed that.
Yeah. No, sometimes I actually use Smith. So I did use Smith and Smythe earlier. All right. So you take care of her emergency, and then you say to the patient, we really should schedule you for, now don't write this down because this is more like what we normally would say. We really should schedule you for a comprehensive evaluation, a nice thorough evaluation or examination to make sure that something like this doesn't happen to you again in the future. So again, don't write that down because that's more pretty much standard of what we were taught to say and what most of us do say, which is that we want to help you prevent stuff like this from happening in the future. Love to have you back for a more complete and thorough exam. We don't have time for that today, yada, yada. So, because they squeezed you in between two patients just to make sure we could accommodate you so you wouldn't have to wait. So all of that is very nice, but it doesn't work. Mrs. Jones or Smythe leaves without scheduling. This patient's not prevention oriented, period. By definition, somebody who comes in just for dental emergencies acts only when they sense an immediate or urgent need. And now this ties into something I said in the very beginning, which was when somebody's asymptomatic, even a good patient, even a routine regular patient who comes in for regular care and has been with you for years, when they are asymptomatic, no matter how much they love and trust you and your team, if they don't sense an immediate and urgent need, even if they believe they kind of need the care, they're not going to do it. Why would they? Think about it. You just got across to them that they need a crown or a filling or whatever it is that you just discussed. Not the emergency patient. This is routine regular care, asymptomatic. So patient didn't know they had a problem. They were in for a routine checkup, cleaning, and exam. You just told them that they needed whatever. Let's say it's a crown or a build up and crown on tooth number 3 because you found whatever. And if you didn't convince them, if you didn't use verbal skills that help them perceive the immediate and urgent need for care, then what they're facing for this thing that they don't really think is necessary right away, what they're facing is taking time off from work or from their loved ones or both, maybe even multiple visits, maybe more than one visit, being injected with a needle, which they hate. I'm a dentist. I've had tons of dental work done. I'm a good patient, but I still don't like being injected. I'm fine with it. I don't move. Usually I don't even feel it much, but I still don't like it. I'm not going to do it if I don't need to do it, if I don't sense the need. You're going to inject them, and then you're going to spin the high speed at 500,000 RPM. Forget it. I'm not coming in. So you got to get that patient to believe that there is something else that has some sense of urgency. All right. So since the emergency patients only come in when they sense an immediate and urgent need, and that's the only reason they're going to call, you've got to get this across to them. Now, it could be maybe they need quadrant prosthetic dentistry, and I'm not talking about an emergency now. I'm talking about routine. Maybe they need quadrant prosthetic dentistry, or maybe it's just 1 or 2 teeth. Doesn't really matter what it is. You got to get that perception across. And so, how do we do that? How do we instill in this emergency patient the feeling, and write this down? You need to instill in your emergency patient the feeling that there is yet another immediate and urgent need that they didn't know about. I'm going to repeat it because this is a concept that we've never been taught and that nobody else is talking about. You gotta help your emergency patient while you're working on whatever it is you're working on to help them out, because they have their need and you gotta take care of their need. But while you're doing that, you got to get across to them that they have some other immediate and urgent need, and yeah, they're asymptomatic on that one. They didn't know about it. So you got to get that across. So how can we motivate them to schedule and show up for additional care? Well, it's not foolproof, but the majority of emergency patients, by definition, because they're not coming in for regular care, have some level of periodontal infection. I repeat that. Not foolproof. In other words, it's not 100% of the time, but since emergency patients, by definition, aren't coming in for any routine or regular care with anybody, most of them have some level of perio. Now, if her emergency, let's say, was a fracture, let's say even with an abscess, tooth number 4, as standard of care, you're not going to commence the emergency treatment until you've at least done a periodontal probing on the entire upper right quadrant. So, it's unless your state has some law that I don't know about, it's not necessary to do a full periodontal exam and full periodontal charting on the entire mouth if you're working on one tooth. But if you didn't probe at least that quadrant, then that would be malpractice. So, and again, if your state says you got to probe the whole mouth, then so be it. I've just never heard that anywhere. So of course you're going to probe, you're going to find what you're going to find. And after you probe, I'm going to use my periodontal verbal skills to help them perceive the immediate need for care specific to perio. I'm not going to use the word bleeding. I don't say to Mrs. Jones, when I was measuring your gums, you were bleeding. Instead, I'm going to say, Mrs. Jones, when I was measuring your gums, they were hemorrhaging. And that's not normal. It's a sign of an active infection. Let me repeat that, because this is part of the verbal skill I want you to write down. Mrs. Jones, when I was measuring, you know, your gums, when we did your gum exam, your gums were hemorrhaging, and Mrs. Jones, that's not normal. It's a sign of an infection. In fact, it's a sign of an active infection. And then I'd point to the radiograph. I'd like to point to the X-ray, by the way, but as you and I both know, you can't actually point to X-rays. I suppose you could, but you can't see them. So how are you going to do that? Quick sip of tea while you think about what I just said. All right, so I point to the radiograph, and the radiograph indicates. I'm sorry. I tell the patient, Mrs. Jones. I do use the word X-ray, by the way, for the patient, because they think it's an X-ray. It's not. It's a radiograph. Okay, so I say, Mrs. Jones, your X-rays indicate that you've already begun to suffer irreversible permanent jawbone damage. I'm going to repeat that because, again, that's one of these things where what we do with our coaching members is word for word, you use these verbal skills and you will find your periodontal acceptance phase 1 going way higher than it's ever been. So again, I'm going to use Mrs. Smith this time. Mrs. Smith, your X-rays, and you're pointing to the X-rays. She can't read the X-ray, but you just point to it. You've just looked at it and you see bone loss. Don't use the words bone loss. Don't use the words bleeding. Use the words hemorrhaging. Use the words, you've already begun to use the word suffer. You've already begun to suffer irreversible permanent jawbone damage. Then I'd show them a graphic that I created, and I'll describe the graphic because I don't have it here, but I'll describe it. It's a profile photo of an attractive 40-ish, and you guys can do this. It's easy enough to do. So you have a woman who's roughly 40 years old. Not the age is important. You don't want to show somebody who's in their 60s or 70s because it would totally miss the point. So you show them somebody in their 40s or so, and you make basically 3 panels on this. I call it just a graphic aid for presentation aid, and we laminate them so it's looks nice. And on the left-hand panel of the 3 panels is the woman in her 40s. In the middle frame, it's the exact same photo, but you've photoshopped it what she would look like immediately after she loses her teeth. So she hasn't had any subsequent bone loss that obviously happens pretty rapidly after the loss of the teeth. This is like post-extraction a week or whatever. So you Photoshop that. Obviously, the vertical dimension is going to be significantly different. Same woman, same 40-year-old woman, but without teeth. And this, I mean, you've seen this. You've seen this in some patients who, unfortunately, their family just didn't know any better, and that's just what they thought happens, and so they let it happen. Right. The final frame on the right. And by the way, in addition to vertical dimension loss, in the Photoshop, you would also put in some wrinkles because that's what's going to happen. And then the final frame on the right shows severe vertical dimension loss because of the continued bone loss over time. So you got this woman who's a pretty woman on the left frame, not so pretty and kind of older looking on the right middle frame. And by the right, she looks like she's in her 70s, even though it's the same woman. Right. After showing the graphic and after using the verbal skills, I would then tie her gum infection in with what we know about the oral systemic link. Remember, a few moments ago, maybe a little bit earlier tonight, we talked about the oral systemic link, and it's a very powerful way to help your patients appreciate the immediate and urgent need for the care. I've identified 30 categories of patients who are at higher risk of potentially severe systemic consequences of oral infection. And I know you guys have been studying this as well, because we've known about it for a decade and a half, probably 20 years. But now, just this last 10 years, and certainly the last 5 years, the volume of great information that helps. Okay, so it's there, it's out there, you can grab it. For example, just to name a few: diabetes, Alzheimer's. And these are things you want to look in their personal history, in their personal and or health history, and figure out which of these, and when I say these, I'm just going to name a few of them, but there's up to 30 of them, which of these would be helpful to discuss with that particular patient, because that's going to ring true for him or for her. Diabetes, Alzheimer's, a family or personal history of heart disease, certainly a TIA, which is a precursor to stroke. And if they had stroke, or if anybody in their family had stroke, now let's say your emergency patient has 5mm perio pockets and bleeding. First, deploy the perioverbal skills, and we did some of them. We did kind of a short version just now. So they understand that they have an active infection, and show them the graphic, what it looks like over a period of time. And by the way, people don't realize what they would look like in fairly short order were they to lose teeth and vertical dimension. So it's very powerful to do the words and the graphic. And then I would say, Mrs. Jones, I wish I had the opportunity to do a full exam for your gums today, and say it kind of almost with remorse that you're really sorry you can't do this for her today. Most often when we find gum infection in one area, it's very, very likely to have already spread. Write that down. It's very likely to have already spread to other parts of your mouth. Unfortunately, because Mary was just able to squeeze you in between two patients for the emergency, and we did want to accommodate you and make sure you got in right away, we don't have the time to perform a thorough examination of the rest of your mouth today. Now, turn to your dental assistant and say, Betty, do me a favor. When Mrs. Jones goes to the front and she's speaking with Nancy, make sure that Nancy gets her in either this week or next week. I don't want her to have to wait because of her gum infection. And say it just as I just said it, kind of quietly, like you don't want other patients in other rooms to hear any of this, that we might be, maybe even moving somebody around to accommodate this patient. But I want you to make sure that Nancy gets, Betty gets her right in. So those are the verbal skills that will change your conversion. They will change your conversion. Now, remember, I did very, very, very conservative numbers. I said if you had only 100 emergencies in a year, and if you could only convert 10% more, A, I'll bet you have 2, 3, 4 times that for emergency patients, and B, 10% is a very low estimate of the increase you're going to get if you use the gem that I just shared with you. Quick sip of tea. Number 7, the one thing staff members say to patients, which could land you in front of your board of registration questioning your right to keep your dental license. Unfortunately, this is one of those that is said totally innocently. The team members have no idea that the harm that it could cause. Mrs. Jones, let's say she owes you some money. A couple of years ago, maybe you did a crown for her, and let's say she paid the first $500 on the day of the prep, and she signed a financial agreement, and it gave you permission to charge your credit card the other 530 days or whatever. Somehow on day 30, your team tries to run the card and it was declined, and maybe even the card was closed down and they closed the account, or bad check, whatever it is. She owes you $500 and you haven't heard from her. You sent her bills, you tried to call, you did everything you were supposed to do, but you never heard from her and you haven't got the money. She calls you, let's say 2 years later. So this is quite a while later. And she says to your receptionist, Nancy, one of my teeth is bothering me. And now, of course, it's unclear to Nancy and to the patient whether it was the crown that you did, or maybe it was the tooth next to the one. Maybe it was something you did. Maybe it was even the one that she owes you the money on. Who knows? Maybe it's another tooth. Regardless, she's called in and she has what she thinks, and she's right. It's an emergency. So Nancy says, she asked her if she can bring in the money, and Mrs. Jones says she can't. So Nancy tells her that she really can't come in unless she shows up with the $500 owed. But she's explained to Nancy she can't bring that, but she'd be happy to bring it in next week. And Nancy says, I'm sorry, I really can't do that. Instruct your team that unless you tell them otherwise, the default should be that we always invite an existing patient with an emergency to come right in, regardless of whether or not they owe you money. A couple of reasons. First of all, it's good karma. Maybe you'll get your money at some point. Maybe you won't. I mean, you might not. It's not really even relevant, but you might. But if you tell her she can't come in, you're never going to get the money. But it isn't even about the money. I don't expect you that you're going to see the $500. So that's not really even the point. The point is to avoid potential charge of abandonment, and you know that. You're aware of abandonment laws. They're the same in every state. Let me rephrase that. The laws are probably different, but there is an abandonment law in every state. So check with your attorney. But most states require that we as a dentist render emergency care until or unless you had formally discontinued the patient. Formally, as in whatever the state's requirements are. The board has some pretty specific requirements, whether it's a certain amount of notice and a certain amount of waiting period and return receipt requested or FedEx signature required, whatever it is. You got to talk to your attorney and make sure you're doing the right thing if you're discontinuing anybody. And even if you did discontinue them, again, there's going to be a waiting period afterwards, during which if they don't have a new dentist, you still need to see them or you're at risk. Bottom line, safest thing to do is just tell your team, just get the patient in the office. Now, does that mean I'm going to do a whole bunch of care on this person who's been a deadbeat? Of course not. It doesn't mean you're going to invest much time or render much extensive care at all. Maybe you write a prescription. Maybe you smooth off a tooth and just make them more comfortable. Maybe you send them to a specialist, which by the way is a great idea, because Did you know that the specialist won't treat them without getting the money? Funny about us general dentists, we're pretty soft about the money. I'm not, but a lot of us are. I think I was. Actually, in my first 15 years, I almost lost my practice and my house. So yeah, I was pretty soft about money in the beginning. But that was only one of my many problems. Fortunately, turned that around about 25 years ago. If your team denies them the requested visit, you refuse to see them, basically, it's potential abandonment, and you may be called in by your board, and they may question your right to have a license to practice. So get them in the chair, do something quick, do something super easy, make them feel better, be nice to them, be really kind and gentle as if they were one of your best patients. And yeah, patient will be happy. Don't hold your breath for the money. Maybe you get it, maybe you don't. Number 8, the irony of 2 words often spoken, which unfortunately have the opposite effect from that which was intended, and how we can fix this and it'll never happen again. I had a periodontist, not Jean-Marie. This is a periodontist before Jean-Marie. I ended up having to let the guy go for a number of reasons, but not because of this. But anyway, I had a periodontist who would use this phrase. It's 2 words. And it haunted me because, well, you'll understand why in a minute. Write these 2 words down. Trust me. Trust me. God, that sounds like a used car salesman. Trust me, Mrs. Jones, based upon your situation. By the way, if you use to be honest with you, that's just as bad. Never use the words trust me or to be honest with you with a patient. When you use those words, the implication is that what I said previously may not have been trustworthy. Let me repeat that. To your patient, when you start out the sentence with trust me or honestly or to be honest, the implication may be taken by the patient that maybe what was said before this wasn't necessarily trustworthy. So my suggestion is, because these are things that we say inadvertently and probably don't even know we're saying, anybody who uses this doesn't really realize that they say this frequently. Team members and doctor help each other out. Team members, if you hear the doctor, if you hear the team member, somebody hears somebody else saying it, when you're away from the patient, just mention it to them. And again, it just sounds like used car. Trust me, Bob, this is the best car you could ever get. It's the best value. There's no problems with this car. Trust me. Good luck with that car. I think I bought that car when I was in my crash and burn years, 25 years ago. All right. Number 9, how to be a hero, even if your patient experiences, they got post-op symptoms or hot or cold sensitivity, and you're still a hero. How does that happen? Well, you want to avoid ever saying the words, no, Mrs. Johnson, it's not likely you're going to have any hot or cold sensitivity. So instead, anytime you drill, anytime you inject anesthetic and you drill into a tooth, Mrs. Jones, it is possible you could have short-term, very short-term hot or cold sensitivity. That would be normal. And then, of course, you want to explain the difference between reversible and irreversible pulpitis. And I'm not going to go into that, but you know how to explain that to the patient, which one is which. And if it's reversible, it's just short-term post-op symptoms which are going to go away. That's all good, and that's expected. That's normal. So let's say you replace a small silver filling. You put in a composite, and inlay, whatever it is you're putting in. The recurrent caries wasn't super deep. Personally, looking at this tooth, you don't anticipate there's really going to be any post-op pain. You can pretty much assume, if not, I wouldn't guarantee, but your assumption is no issue at all. If you tell your patient that they're not likely to have any sensitivity, then you are setting yourself up for failure, potentially, and an unhappy patient. So if you had to inject, and if you had to run a high speed, just tell the patient that there is a possibility of postoperative sensitivity. I wouldn't use those words. I just say of the possibility you could get hot or cold sensitivity. Tell them they could expect a little bit, and that you've gone into the difference between pain that's short term that goes away in a few seconds, or something that happens unstimulated or out of the blue or wakes them up at night and all that stuff. So that's that. But you will really do yourself an enormous favor if you always let them know that this is a possibility. Why? Because it is a possibility. It totally is. All right, number 10, excuse me. What to say when your state board does not allow your hygienist to diagnose or treatment plan. Your hygienist says, Mrs. Jones, you've got a very deep cavity showing up here, and she points to the x-rays. You got a really deep cavity showing up on your x-rays, and you're going to need, and then whatever she says, she goes into, whatever she thinks the doctor's going to do based on her experience with having worked with you for 5 years or 10 years or whatever it is. So, Mrs. Jones, you've got a very deep cavity here. She's pointing to the x-ray. Um, I'm quite sure that Dr. Jones, when he comes in, is going to recommend that you, and then whatever the thing is that you pretty much always do when she sees something like that. Now, you may have heard my theory of the bobble-headed dog. Danny, have you ever heard my theory of the bobble-headed dog?
Not directly. No, I have not. I can't wait to, though.
No, see, this is totally a theory, but it's based in reality. Here's what first of all, it came from pulling up at a stoplight one day in downtown Framingham, which is where one of my two practices was. And I pull up at a stoplight, and I'm looking at the back shelf of the car right in front of me, the rear hood, the rear deck, and there's one of those little bobble-headed dogs staring out the back. And of course, they had just stopped right in front of me at the stoplight, and so the bobble-headed dog, the head's going up and down. And then I was on my way into my practice, and I'm thinking, I know how I can use this. When I walk into a hygiene room, and I'm going to be doing a re-examination, only after the hygienist has already made the patient aware of and this is an asymptomatic patient, because remember earlier we said that 95% of our patients as a GP, 90 to 95% of them are asymptomatic, so they don't even know that they have these problems. I want to walk into that hygiene room for the re-exam only after that hygienist has already made the patient aware of these asymptomatic problems. I would rather be a second opinion and just bobble my head up and down and say, yeah, that really is a concern. I'm glad you called me in, Nancy. Let me have you, if you could just take the computer and make some notes on what we should be doing here. So again, I don't want to be the first bearer of bad news. It can be really difficult to get your patients who are asymptomatic to accept that they have a problem. In the absence of symptoms, it's tough, but it's even tougher in the absence of symptoms when the dentist is the first one to tell them about it. I want to be that bobble-headed dog, and we worked this out too. It was beautiful. We had 5 hygienists between the two practices. Every one of them was trained to let the patient know what they saw, what the problems were, what the potential write this down, the potential consequences of inaction. I was speaking to one of my Freedom Summit coaching members today, and the hygienist was talking about how they speak with their patients about getting a home sleep study and why they should have it. And this is a patient who had no idea that they need it. So we're going into basically verbal skills. And what I noticed was that their verbal skills were excellent. They had been to a course on sleep apnea and breathing disorders and treatments. And so they'd been to a really good course. So I said, let's role play. You walk through it with me. So I'm the patient. I don't know anything about it. I didn't know I even had a problem. And they walked me all the way through it. And it was crystal clear. But they never once mentioned anything about the potential consequences of inaction. And had I been that patient, I never would have scheduled for something that they were telling me that I needed when it didn't really sound like there was any real reason to do it. So the potential consequences of inaction. Dan Kennedy, again, one of my marketing mentors and business mentors from many years back, says that there is a 3-step process to sales: problem, agitate, solution. Problem is whatever you see as a diagnosis in dentistry. Solution is whatever the treatment plan is. We have been taught to short circuit the sales process by going from problem to solution. Mrs. Jones, I see that you have XYZ. What we're going to need to do is an ABC, whatever the recommended treatment is, and it doesn't work. The patient will not buy in if they don't own the problem, and they don't own the problem until they see the potential consequences of inaction. What could happen if I don't do anything, and when might that happen? And we don't necessarily know, but if it's bad enough, you can get them to understand and appreciate that there is a need for treatment. All right, so let me go back to the bobble-headed dog. That was a little bit off course, but it's important that we discuss that as part of this. So I walk into the room, and my hygienist tells me in front of my patient, Dr. Orent, I'm concerned about, and then she's, whatever the problem is, that Mrs. Jones has in her upper right quadrant. So let's say she sees 2 teeth with wide open margins and 30-year-old amalgams and whatever. So she says, Dr. Orent, I'm really concerned about the 2 teeth in the upper right with wide open margins. And I told Mrs. Jones in the upper right. So she's already gone over all this with Mrs. Jones. I'm kind of the second person in the room now. So I'm like the little dog in the back of the shelf of the car, and I'm just bobbing my head up and down, saying to the patient and to the hygienist that, again, that I too am concerned, and I'm glad she called me in. And when we walk in, as a dentist, when we walk into the recall exam, the traditional way, which is after, let's say Becky is your hygienist. So Becky's been with Mrs. Jones for the better part of an hour. The end of the visit, we come into the room. And by the way, I don't believe in going in at the end either, because that causes all sorts of logistical problems. I come in when all their facts and findings and discussion of potential consequences and what might be needed. When that's done, periodontal exam's done, cancer, when all those things are done, I come in. But anyway, it gives me more of a window of time, so I'm not told at the last second that you got to get in here, we're done with the visit. So she's been in there, Mrs. Jones been in there for the better part of an hour. And my hygienist hasn't said a word about the problem. And in that situation, if I'm the doctor and I walk in and I start talking about these problems that are in need of treatment and that are going to cost $3,000, $4,000, $5,000, patient's asymptomatic. Just been with my hygienist for almost an hour who never said a word about any of these things. Patient might think that I'm just after the money. And the truth is they have a problem, but I can't fault them for not knowing it, because I walked into the room kind of second in, and the first one never said anything. And that's a real problem. Now, if we were sitting eye to eye, knee to knee, toe to toe, and chatting about this, one of the concerns that I anticipate that you might raise, and you would be right if you raise this concern, is that hygienists in my state aren't allowed to diagnose a treatment plan. So if you're thinking that to yourself, which is that it's not legal in my state, you're right. It's not allowed in any of the 50 states or in Canada in any of the provinces. However, your hygienist, in my opinion, if she's been there for a few years, knows what you do, she's a good qualified hygienist, been working with you for a while. She's certainly qualified to point out decay, an obvious lucency, which is an abscess, deep dentin fracture if she's using transillumination, periodontal infection after she measured the gums. Now, it doesn't mean you're always going to say exactly the same thing, so it doesn't have to be perfect, but to get him or her, we had 2 male, 3 female, to get him or her to pre-frame expectations, write that down. It's called pre-framing of expectations. To get them to pre-frame expectations before we walk into the room will change your practice and change your life. It totally will change everything for you. Because most of the time they're going to have a pretty good idea of what the problem is, and maybe even probably what most of the likely options you're going to recommend. I'm not talking about some crazy perioproths case that's a $50,000, $80,000 case. She's not going to know, but a few teeth, she's going to know. So how do we get around the fact that they can't diagnose a treatment plan legally in any of the states? Well, with my 5 hygienists in the 2 practices, what I did, and you need to check with your attorney, because I'm not an attorney, but check with your attorney and make sure that they're okay with this. Mine was like, yeah, it's totally fine. I trained them all to say, Mrs. Jones, I'm not a doctor, and so I can't diagnose your treatment plan, but I've seen this 1,000 times, and I can tell you exactly what Dr. Orent's going to say when he walks into the room. He's going to tell you, and then she goes into whatever it is. I'm going to repeat that because that's a critical verbal skill. As long as your attorney's okay with it, it's a critical verbal skill, because it's basically, in marketing or sales, it's what's called a bridge. You've just seen all these problems. You've just discussed all these problems and made the patient aware, but you haven't really diagnosed. You haven't said this is what it is. You've just kind of started to talk about it, maybe shown them a photo. And the bridge is, Mrs. Jones, I'm not a doctor, so I really can't diagnose, and I certainly can't treatment plan, but I have seen it hundreds or thousands of times, whatever. I can tell you, when Dr. Orent walks in the room, he's going to tell you that, and then just tell him. It's really cool. This works so well. Number 11, the single word spoken by a nurse that caused my mom never to go back. Now, I told you about this earlier. I mentioned that there was one word, one thing said in one short sentence. With respect to new patients who are older than your team member. So let's say your team member, and I don't care what the age is. So let's say your team member is 28 or 32, whatever the team member's age is. And let's say the patient is 45 or 50 or 60. So whatever Doesn't really matter as long as you're not looking at this word is not an issue if the patient is much younger. So let's say your team member is 40 and the patient is 12 or 15 or 18. Then this is not an issue. This is when you're looking at somebody who's older than you are and it's a new patient. So I would recommend that your team member address them as Mrs. or Mr. or Doctor or whatever the patient's name is with the title that they had given you in their intake form until they say otherwise. So what if the patient says it's okay to call her by the first name? Of course, that's fine. Oh, please call me, Bob or whatever. I always had patients call me Tom. They knew I was a doctor. They saw the licenses on the wall and the degrees and things. So I wanted to just be able to talk to them and them to talk to me. And there's already enough of a barrier between that doctor-patient kind of pedestal. So I tried not to allow that to happen. But with the patient, you always call them by the last name until they give you the opportunity. The team, this is also really important. The team should never ask permission, because sometimes I'll hear a team member saying, "Oh, may I call you Bob? Or may I call you Lucy?" Well, it puts the patient in a very awkward position because they feel that they might have to say yes, because it's awkward to say, "Well, no, I'd prefer that you call me by my last." They're probably not going to say that. Meanwhile, they may feel that. So when your team member calls your new patient by her last name, yeah, maybe the team, I'm sorry, the team member calls the patient by the last name. Maybe the team member says, "Yeah, please call me Mary. That's great." My mother left her physician's office because I think it was not a nurse, it was a medical assistant. Medical assistant came out with the chart and announced to the whole waiting room, Daisy, and she went right up to her, she said, "Daisy, you must be Daisy." Now, my mother at the time was like in her 70s and she was mortified. She's just kind of a traditional, old-fashioned, that generation. But you got to respect it and you got to anticipate it. And the only way to anticipate it is by default to use the last name until you're told otherwise. Number 12, we got a lot of pet peeves. My dad's linguistic pet peeve, which is now mine too, which squanders opportunity. It squanders opportunity. So the patient says, "Thank you for squeezing her in." And she's really happy and appreciative. And maybe it was a treatment that, you moved her up ahead. Maybe you got her in a little bit sooner, whatever it is. Maybe it was an emergency, whatever it was. Do not ever use the two words when she thanks you for whatever it is. Don't ever say "no problem." And unfortunately, in our society, we've pretty much become hardened to we always just say it, "no problem." You hear it a lot. When a patient thanks you for something that you did, your response should never be "no problem" or "you're welcome" or "no problem, you're welcome." Any combination of those, they're all bad. It's a super letdown for the patient. At the moment of expressed appreciation, Cialdini, and his full name is actually Dr. Robert Cialdini, and you may have read or heard about him. He's a Regents Professor of Psych at Arizona State. But anyway, Cialdini says you have a very brief window of time. It's a brief window of opportunity when somebody thanks you. That moment of gratitude, don't squander it by saying "no problem." Furthermore, when you say "no problem," it's like telling the patient that it didn't take any effort. You didn't put much into it at all. Like it was no big deal. Now, even though you're not saying any of that, that's the implication. It was no issue, wasn't a lot off my back. The worst part about saying "no problem" is that the patient then feels that they're nobody special. You would have done this for anybody. She's not special. When in fact, the patient has to be special. The patient has to be our focus. So you're also devaluing what you did for the patient. So not only are you saying you would have done it for anybody and that she's not special, but you're also lessening the value of what you did. So instead, I would say something to the effect of, "Mary, it was my pleasure," or "You're most welcome. I was happy to do it. I was so happy to do that for you. I'm so glad that worked out. I'm so glad that we were able to do this for you. It was certainly my pleasure." Now, if you want some fun and an education in the language of, the language of 5-star service, go into the Four Seasons or the Ritz-Carlton and listen carefully to the team. I did this a couple times with my entire team. We did it kind of for a fun day. I called it kind of the VIP 5-star day of the stars, and we rented a couple limos and brought our team members into Boston and just had a fun time. We had lunch at the Ritz-Carlton. We went into the Four Seasons. And the assignment was, this was not just for fun. The assignment was look around, listen, get the feeling. What's the vibe like? How do you feel when you're in there? What do they say to you? How do they stand? You will never hear anyone at the Ritz or at the Four Seasons or at any level of that kind of customer service. You'll never hear them respond with no problem. They just will never say those two words, at least not together. Number 13, what to say to a patient. I'm sorry, what to say when a patient asks for a day of the week that you're not open, you're routinely closed on that day. Mrs. Jones asks Mary if she could have an appointment on Wednesday afternoon. Now, the public's perception of us as dentists is that we are too rich and have too easy a job, and we're all making a fortune, and goodness, what an easy job they have. Nothing could be further from the truth. Dentistry is really, really tough. I mean, I loved my practicing years, the 22 years. I loved occlusion, went through all the Dawson courses, and in fact, Pete wrote the foreword to one of my books. I loved occlusion and reconstruction. I also loved aesthetic work. I loved smile redesign. I loved all this stuff. But love and passion aside, it's a tough job, not easy. So their perception is we got an easy, quick job, and an easy job, and we're making a lot of money. The care that you and I render to the public it's a wonderful service, and it's worth so much. I think it's worth way more than we could ever charge them. I honestly believe that the value of what we do for patients is beyond anything that we would ever charge. So never say to the patient, no, I'm sorry, Dr. White's closed on every Wednesday afternoon. And it's like, no. The patients assume that we get to keep the majority of the fee that they pay. So let's say they pay $1,000 for something. They don't realize that you're not keeping, 800 of that. They don't know that. They don't know that you're not keeping 750 of that. Unfortunately, it's just the opposite. Most dentists are doing 25% net, 30% net. If you're doing well, you're doing 35% net. And a GP keeping 40% net or more is outstanding. Now, the specialists are smart. Not that we're not. I think we're pretty savvy as well. But the specialists, they're keeping, a lot of them are keeping 50%. Anyway, all that aside, the patients assume we're keeping a lot of money and the dentists are making too much money. So the team can only fuel that fire when we say, I'm sorry, Dr. Smith takes Saturdays, Sundays, and Wednesdays off. And by the way, you might not say all those days, but they know you're never there on a weekend because maybe they tried to get in on a weekend before and you said you're closed weekends, and now you're trying to get in on a Wednesday and you're not open any Wednesday. Okay, so what do you do instead? Instead of saying, no, I'm sorry, he's closed on Wednesdays, Mrs. Jones says, could I have, do you have a Wednesday available? Maybe a Wednesday morning would be great. Do not say anything. Look into the book as if you're looking to see if there's a Wednesday available. So just look into the book, which of course I'm using as a euphemism because there is no book. Look into your computer, into your schedule, and then look back at her and say, I am sorry, I don't have a Wednesday available, but we do have this Friday at 1. We also have next Monday at 8 a.m. So give them the dual alternative assumptive close on 2 days and different times that you do have available. And that's what it is. In appreciation for you guys joining me and Danny, that's not really good English, Danny and me. Yeah, I think that's it. Danny and me, I have a free bonus for you if any of these sound like you. So this will be good for you. You'll enjoy this. You'll appreciate it. I think it'll be really helpful for you if any of these sound like you. Do you resent writing off 15 or 20%, or in many cases even more than that, to PPO in-network contracts while your team members are wasting more time chasing claim denials than helping your patients? Do you start out every day wondering where the patients and the money are going to come from? Do you see other dentists making the kind of money that you would like, the income that you would love to have, but you have no idea how they're doing that? At the end of the month, there are way more bills to pay than money in your bank account. Are you working way too hard in your practice and feel like you're burning yourself out? Do you worry that you're another year closer to when you really should be able to retire, but you're slipping further and further away from really ever having a financially secure retirement? If you want to reduce your dependence on PPOs by 25%, help more patients achieve optimal health and longevity, add $300,000 annual revenue, even while working 1 day less than you're currently working each week. I've set aside some time in the next 48 hours to chat with you personally, be me, just us, to learn what's working for you in your practice and also what's not working, and help you develop a short list specific to your practice of at least 6, sometimes more, but at least 6, what I call 10X factors. And we'll develop on that call what I call your roadmap to freedom. And freedom in this case talks about not just financial freedom, but also professional freedom, free to do whatever you want to do, whatever you feel is best for your patients, and not have to take so many other factors into consideration. Whatever your biggest challenges are, we've seen them. We know how to overcome them. This is Dr. Jill Smith. Jill already had an amazing, thriving downtown Boston practice. I mentioned her earlier because she was the one who told me that the middle of her day tends to be a little bit heavier because she's right smack downtown Boston, right off State Street, which is a beautiful area of Boston. So when we met, she already had a thriving practice, but she said she just wanted more time to spend with her daughter. They share a mutual love of horses. They're both equestrian eventers, as is my wife, Elizabeth. So Jill says, you know, she wanted to make more money than she was and spend less time at the office so that she could have more time to ride with her daughter at events. And I helped Jill with one of my gems, which is called the immersion method. We mapped out, just as I'm talking about with you here, we mapped out maybe 6 or 7 10X factors that she was missing in the practice after we discussed, you know, what was working, what was not working. And during her first year as a Freedom Summit member, she accomplished, actually she accomplished both of her goals. She added nearly $400,000 in revenue, and she was working less. So if you guys would like to schedule a breakthrough strategy session, we'll get on the phone, be about an hour. During the call, we'll work out with you, we'll craft a step-by-step game plan to hit your revenue goals, whatever that is. Might be 200,000, what you tell me, what do you want to achieve? And we'll talk about how to do that. This is Dr. Kevin Mahoney. He put most of his time and most of his effort into advancing his clinical training. He did what I did for my first 15 years before I turned my practice around. In addition to advanced training in prosthetics and in sleep dentistry, he's also a fellow of the American Dental Society of Anesthesiology, and there are not that many of these guys who go that far in training, where he's actually an anesthesiologist as well, practicing GP, high-level prosthetics, sleep dentistry, and anesthesiology. So Kevin says to me, he had focused so much on his clinical skills, and that's what we all do. It's what I thought was going to help me really build the practice and help me feed my family, and it didn't. That wasn't what worked. And you need to be a good dentist. I mean, you need to have great clinical skills. But he says he neglected to learn how to get his patients to accept optimal care. He used my 4-step system for selling quadrant prosthetic dentistry, and he increased his net income by over 35% in just 12 months. So we'll come up with a plan to reduce your dependency on PPOs, help your patients get into much better health. And if you want to work less, that can be done as well. The cost for the session is free. It's my gift for you, just as I say, an appreciation for your being here tonight. One of my members, George Landris, actually, I mentioned George earlier. I said that I was talking with one of our offices in Danbury in Connecticut. So it was George I was referencing. He told me before he joined us in Freedom Summit, he said he was frustrated that even with his advanced training in prosthetics, more often than not, he was doing 1 or 2 tooth dentistry. So if you look at what he was doing all day, it was 1 tooth, 2 teeth. He was reluctant to offer his best care for fear that his patients wouldn't accept it. During his first week using my 4-step system, 6 of George's patients accepted 1 quadrant of crown and bridge for a total of $29,860. Again, first week that he used the 4-step system for helping the patients perceive the need for prosthetic dentistry, 1 quadrant at a time, close to $30,000. Now, I'm not saying that you're going to get those extraordinary results. George is an extraordinary dentist and an extraordinary human being. He's on this mission to deliver the very best care that he possibly can on the planet. He just didn't have the gems, didn't have the strategies or the logistics on how to do that and how to discuss it with the patients. In less than a year from being with Freedom Summit, George went from $600,000 to $1 million practice. There is a catch. There's always a catch. The breakthrough strategy session is not for everybody. So here's who it is for. You must be a general dentist. You must be the owner of your practice. You need to be in solo or small group private practice. And you have to have that desire to really help your patients achieve the level of health that you know that they could, that you wish that you'd been able to do. You know clinically you can do it, but it's just a matter of getting them to accept and pay for it. So if this is, if this is you, then book your breakthrough session now. And to do that, you would go to freedomsummitcoaching.com/aim. And Danny just
I've actually taken the liberty of sharing that via the chat box for everyone. So it's easy. You can click on it now, or you can copy and paste it. But yeah, I'll let you go ahead and finish up. And then
I appreciate you doing that. No, that makes it way easier. Do write it down just in case for some reason that link doesn't work, or you're on a phone, or for some reason it's not going to work for you. So it's freedomsummitcoaching.com/aim. But as Danny said, you should be able to just click on it. So many of my team training practice transformation members, the Freedom Summit folks, have told me that they waited for months, some of them even years, to pull the trigger and talk to me about, their practice and do one of the free strategy sessions, which has absolutely zero obligation. If during that strategy session I don't feel that I can help you, I'm going to tell you that. And if there's somebody who I think is better able to help you with whatever specific needs your practice has, I'll make that referral as well. If I think that there is a good fit, then we can talk about, how we can make that happen as well. But one thing I will promise you is it will be 60 minutes of the best. It'll be one of the best hours you've ever spent working on your business. There was one woman in particular, I'll never forget. This goes back to the people wait too long to just do the things that they really need to do in order to get to where they want to be. There was one woman, she was in tears. It was Sylvia Poole. It was the doctor's wife, Dr. Russ Poole. Sylvia and her husband, Dr. Russ Poole, they were in their 70s when I met them, in their 70s. And they had had a terribly difficult life. Financially, it had been really, really, really tough for them. And after about 10 months, after 10 months in Freedom Summit, Sylvia was attending a program and she came up to me and she was in tears. I was like, what happened? And she said that this had been the best year of their life. And she said, I have one regret. And what's your regret? She broke down crying and she said that she told me how difficult their life had been. And she said her one regret was she wished they had met me decades before. So this is a woman in her 70s who, we happened to meet. She didn't know anything about the program prior to that. And so Karen Lamb, and you can see it on your screen. Excuse me, Karen Lamb, this is one of my favorite quotes. A year from now, you'll wish that you had started today. So at least let's talk, and let's talk about, what's working, what's not, and what are some of the things that I've seen over and over. We've been doing this for just over 20 years, this particular program. And what are some of the things that I see that others are doing that maybe you've missed that would be the easiest things for you to start with? So Danny, with that, I'm happy to take questions. And of course, Danny is happy to take questions as well.
I am, and I'm happy to thank you for the quality time. To put it mildly, I mentioned how long I've known you. I've been to many of your meetings, and this truly is, folks, the sort of the tip of the ice, the tip of the diamond, to use the GEMS analogy.
I love it.
You just got 13 of them. Tom has accumulated thousands, and he's offering that to you, and I think you'll all make the decision that's right for you. And I'm glad that we packed in so much information in a relatively short period of time. We don't have a whole lot of time for questions, but let me jump in on a couple and then leave time for some concluding remarks. You mentioned the oral systemic link. What sorts of success are you seeing with your clients gaining acceptance for effective preventive treatment like salivary finger stick testing, sleep studies, etc.?
Really good question. So I'm going to answer that question, and I'm going to answer another question that kind of goes hand in hand with that. Excuse me. We do some marketing for our members to bring in new patients, kind of done for you stuff through social media at amazing results with it. But my point is, we've had some of our members ask similar questions where they said, we do salivary testing, we do finger stick, we do measurements. They do all of these things, which are really that hybrid between dentistry, where dentistry gets into medicine, and you've got to, it's no longer you're a dentist, we're not part of the rest of the body. All right, so we've had several of our members ask our marketing experts who are creating the done for you ads. They're saying, oh, can we do typically, well, I'm not getting into what we normally do, but the question, because I know we're kind of out of time, but typically they'll ask, could we market that? Can you use social media or traditional marketing? Can you help us market that? And the answer is I wouldn't recommend it. Not that it's not an amazing service. It is. It's an important service. But patients don't buy prevention. They just will not buy prevention. So the way to do that would be to, again, go right to the consequences of inaction. So let's talk about a diabetic patient, because this is one that's very common in our verbal skills. Let's say Mrs. Jones has some level of periodontal disease. We want to do further testing, but she's asymptomatic. She didn't even know she has a problem. We just found this during a routine periodontal exam. So you would talk to Mrs. Jones about the fact that there is a link between diabetes and periodontal disease, and that periodontal, and by the way, I wouldn't call it periodontal disease. I would use the words gum disease or gum infection. So Mrs. Jones, given that you're diabetic, it's really important that we discuss. Now, you've already talked about the gum infection. So now you say, Mrs. Jones, it's really important that we discuss the ramifications of being a diabetic living with gum infection. Unfortunately, gum infection, it has no symptoms. You didn't know you had it. The infection, the bacteria circulates around your body. It's called a systemic infection, which simply means that the bacteria is going around your system. And there's no symptoms to that either. As a diabetic, and your physician may have told you, there's something called end arterial, I can't even say the word, end arterial circulatory disorder. And in English, all that means is your circulation isn't real good in your fingers and your toes. The further away from your heart you go, the more difficult it is for your circulation to clear an infection. And that's why your gums, your fingers, and your toes are the first to really experience more infection than somebody who isn't diabetic. Down the road, it's possible, and I'm sure your physician has talked to you about this, if you don't maintain excellent health and really do everything you can to eliminate infection anywhere in your body, that type of an infection will pull, the bacteria will pull in the extremities, and there are diabetics who end up losing fingers, losing toes, losing limbs, in fact, and that at that point it can become life-threatening. So,
well, just to be, yeah, I'm sorry, go ahead, finish, please.
I was going to wrap it up by saying, write down those three words again, consequences of inaction. Now tie it into what you know about whatever it is that you're trying to help them with. So if it's salivary testing, if it's testing for different enzymes, whatever it is you're trying to help them with, try to tie in whichever, by the way, another tie-in that's really good, which has only recently been well-researched and well-documented, is Alzheimer's and dementia. There are significant links, and they're cited in the journals. There's significant links between, excuse me, Alzheimer's and dementia and periodontal infection, and you would use the word gum infection. Now, I would be clear, your gum infection doesn't cause Alzheimer's, so we're not saying that it causes it, but it contributes to earlier onset and higher severity. And both of those things should scare your patient to death. And somebody, devil's advocate's going to say to me, but Tom, I don't want to scare my patients. Great. Then you're putting them at risk of not accepting the recommended treatment, and you're putting them at risk of suffering from whatever the consequences are. And in the case of Alzheimer's and dementia, it's life-changing, if not life-ending.
Right. So you can deal with dealing with the fear, or you can deal with the guilt that might ensue.
Yep.
And just to clarify, Tom, when you say you wouldn't recommend social media, I think what you're saying is that you wouldn't recommend using mention of the links between oral.
It's not my. Yeah,
it's.
I'm not trying to.
Well, because Well, right, and I don't think that it's appropriate as an external marketing message. I think that this is more of a patient education tool that you run the race at the pace of the particular patient as the situations arise.
100%
And
agree.
yeah, and just to put in a quick plug, you know that I was the one of the founders of the American Academy for Oral Systemic Health back in October of 2010. So this is something that I'm very passionate about. And just if you want to learn more, you want to kind of tap into the links and the research that comes down. I maintain a pretty active LinkedIn group, and so if you're a member of LinkedIn and you want to go, the keyword to apply for membership in the group is AAOSH, which is short for the American Academy for Oral Systemic Health. And then, well, one quick question, and then we're going to wrap things up. But everybody else, thank you for such a lively group. And Tom has promised that he'll answer your questions offline, or make sure and just sign up for the complimentary session that he's offered, and he'll do more than that. Last question: does your summit include personal visits?
Does Freedom
make
Summit?
House calls.
You're
Yeah.
talking about Freedom Summit. The answer is no, but kind of. With our virtual technology, we will do 30-minute one-on-one with a certified coach once a week. We will do calls with me twice a month, and those are open to any of the doctors in the program, and that's always very, very small group, just a handful of people. We have a concierge who's assigned to you. So in addition to me, a coach, and a concierge, the concierge will do, depending on which level of the program, they'll do as many as 4 to 6 half-day programs, just you. It's a personal one-on-one, and it's all virtual through Zoom.
Very good. All right. Well, thank you again. And I just want to remind everybody, in a few days, you'll receive an email with instructions on how to receive your CE credit. I now want to invite you to mark your calendars for Thursday, June 17th at 6 p.m. Central Time, when my guest will be Eva Grazel, whose presentation is entitled Protect Yourself from Liability and Save a Life. Talk about the oral systemic connection. Raise the bar on oral cancer screenings and patient education. It all happens on Thursday, June 17th at 6 p.m. Central. Until then, this is Danny Bobrow thanking you for your ongoing commitment to practice perfection. Goodbye, everybody.
Thank you, Danny.